Oh, hmm. We'll wait for one more attendee and then we'll get going. All right, let me get going here. Okay, so this is a tracing from a patient who has a defibrillator. And the question I have for you is what's going on in this tracing and why? So why don't we ask the newest bride in the group, Dr. Marshall, if she has any thoughts on this.
Good morning.
Good morning.
All right.
Congratulations.
Thank you, thank you, thank you. So looking at the two, looks like we have two leads,
And
and
I'll just for the sake of clarity, this is continuous from the
like
top
time. Okay,
top to the bottom. Sorry.
okay. And like you're saying, the three boxes are like this, like the top one is the same one throughout, right?
Yes, exactly.
Okay,
The that's a good point. The channels are the same in all.
okay,
Yes.
okay. So unusual standard for like rate or no? Yeah.
Yep, yep. And
Okay.
it's actually giving you the R to R intervals, right?
Uh-huh.
If you look, it's giving it to you, which is nice.
Oh, I see. Okay. So what stands out to me is you look at the bottom third, like the bottom box, and the QRS morphology of both leads looks distinctly different. You even see it in the third, like next to it. And the QRS complex is also wider.
Mhm.
Um, so there looks like how many beats? 1, 2, 3, 8. So it looks like 8 beats of ventricular tachycardia. That is faster too than the rate before. But then you see it convert back to the usual kind of typical morphology, or closer to the usual morphology that we see before. So what I would say is it looks like you ramp up into a ventricular tachycardia and then convert back. I don't think in terms of for how long it was that it delivered a shock, because I also don't see a pause that would like correlate with that.
Okay. So basically, what's happening here, you are correct. There's an obvious and big change here in the last panel, right?
Mm-hmm.
From this wide to a narrow. Basically, what's happening here is the patient is going below. So when defibrillators are programmed, usually one of the defaults is to have anti-tachycardia pacing on. So if a person's heart rate dips above a certain rate, what happens is that the device will start to while it's charging. In other words, so let's say it meets the criteria, and in this case, we'll say the criteria is a cycle length less than 300 milliseconds or a rate of 200. What it will do is, while it's charging, the device will try to pace terminate the tachycardia.
Oh, okay.
And so what we're seeing here, um, I think, is that the patient is sort of I think they might be in sinus tach,
Mm-hmm.
little over around 200. and the device actually starts pacing, and then it terminates it. But I guess it's probably VT, because why would sinus tach terminate with rapid V pacing?
Yeah.
But what it does is it paces faster and faster. You see here the cycle length is 250,
Yeah.
and then it breaks.
Mm-hmm.
So this is, this is an example of anti-tachycardia pacing. Now, um, some most of the time we leave this feature on. I'll tell you that when defibrillators first had this feature, I remember when I was a fellow, we used to routinely induce VF in everybody in whom we put a defibrillator. It's what we would call defibrillation thresholding testing. So patient would have the defibrillator implanted, and before you put your final sutures in, you would instruct the device to put an R on T, or to pace at a very rapid rate and induce VF. And the goal was to determine that the patient could, rather that the device could both sense the arrhythmia and terminate the arrhythmia with an adequate safety margin between what it was used to deliver the shock and what the maximal output of the device was. And we would eat, not only would we test it in the operating room, but we would very often bring them back the next day and retest them. Now, part of the reason that we did that was two things. One, we didn't really know very much about defibrillators and how, what we could consider to be a safe, safety margin. The other issue was that defibrillators at that time didn't have as much power. So today, a standard defibrillator delivers about 36 to 38 joules. Oftentimes you'll see 40 joules, but that's what's stored in the device. But 36 joules, 38 joules is a high amount of energy for an internal defibrillator. In the prior era, there were devices that delivered that much energy, but they were special devices. They would call them high energy boxes. And so if you failed, so the standard is that we'd like to see a 10 joule safety margin between what is actually needed to terminate an arrhythmia and what actually will terminate it, and the maximal amount of the device, rather. So, for example, if you had a 25 or a 26 joule device, which was fairly standard in the past, you would have to make sure that at least at 16 joules, you could terminate the tachycardia, for example. And sometimes it would work and sometimes it wouldn't. And if it didn't, one of the approaches, there were multiple things you could do to lower the defibrillation threshold, but the easiest was to just change the device for a high energy device. Of course, the defibrillator companies didn't really like this, because the policies at that time were that if their device failed, they would give you the new device with the higher energy for the same cost as the device you had just put in. So you'd basically get two defibrillators for the price of one. Eventually, all defibrillators, or most defibrillators, were manufactured at high energy. And today, all the devices we put in have this higher energy. And so we don't see failure that often. But one of the things that that became popular was this anti-tachycardia pacing. And I remember one time during defibrillation testing, we decided to see if the anti-tachycardia pacing would work in a patient, because they had a lot of tachycardia that was monomorphic. And there was a hope that rather than getting shocked, maybe this patient would have pace termination of his arrhythmia. And what happened during the testing was that the pacing actually it slowed the VT to a rate that was below the detection zone, but it didn't stop it. That was actually frightening to us, because it meant that basically we converted VT at like 210 into VT at 190. And the concern was that the patient could have serious hemodynamic embarrassment from that without a therapy from the device. So one has to be careful with this, but there are many patients in whom pacing is helpful. So most defibrillators, while they are charging, which typically takes anywhere between 5 and 10 seconds, sometimes even as long as 15 seconds, will attempt to pace terminate an arrhythmia, and that's what happened here. So okay, interesting tracing. Okay, there's another tracing. All right, so this is patient who came to see us, is an asymptomatic 12-year-old boy, And this is the tracing. So my question to you is, what is the diagnosis? What is the workup? What should we do about this? So I'm going to ask Dr. Bezdakova for her insights into this.
Good morning, Dr. Pass.
Morning.
Looking at this EKG, it looks like we're in sinus rhythm. And then just looking at the rhythm strip, it looks like, I believe those are PVCs.
Okay.
Um,
Are
and
they
so,
okay? Keep going. I'm sorry to interrupt you.
no, sorry, what were you gonna say?
No, no, please continue.
So it looks like they're PVCs, but it also looks looking at the rhythm strip, the on the fourth beat, the PR interval is shortened, so it also looks like it's pre-excited.
Mhm.
Um, and then going further along in the rhythm strip, you see that I believe there's that one beat that's the PR interval is back to the baseline PR interval, and then it's pre-excited again.
Mhm.
So I'd be, concerned that this patient has WPW, given that there's pre-excitation.
So you are canceling your first comment about PVCs and are settling on
Yes,
pre-excitation, WPW.
yes,
Am I
yes, correct.
accurately representing your view on this EKG? I agree with you. This is a patient, and so why are these beats have a normal PR and these don't?
um,
What would we
maybe because
call such a patient?
um, in I might be saying wrong. That they're intermittently pre-excited.
You would be saying it 100% correctly. That is exactly
Okay.
how we would say it. So this patient is intermittently pre-excited, and amazingly, on the same tracing, we're seeing it coming and going. So oftentimes, when
Mm-hmm.
people are intermittently pre-excited, for example, when people are referred to me, every once in a while, somebody will send me a patient who has tachycardia and they're not pre-excited in their office, and I see pre-excitation on the EKG in my office, or alternatively, they are billed as having pre-excitation, but actually do not have pre-excitation when I see them. This case, patient actually is demonstrating intermittent pre-excitation in the same 12 seconds on the 12 lead ECG. So this is a nice little diagnostic gift. Okay, so if this child were asymptomatic, what would you think about this patient? The family, somebody wants to put him, let's say, on Ritalin for ADHD. So does this patient? So the diagnosis is intermittent ventricular preexcitation or intermittent WPW.
Mm-hmm.
And what, if any, workup is necessary, or are you okay with what you've seen so far?
Oh, I would wanna put a Zio, a Holter monitor on him, just to see if he has any episodes of SVT. Although he says he's asymptomatic, and and a 48-hour
Okay.
time period may not be the best, but I would still want to see what
Okay, so
what
you
that
you
is.
do that, and there is no SVT. He's a good historian.
Okay, good. And then I'd like to get a baseline echo just to see how his function is. We have a marker of if he's had tachycardia, yeah, in the
Okay,
past.
so you're using the echo as like the hemoglobin A1C of tachycardia-induced cardiomyopathy. You don't trust this boy. You think he's lying to you. What would be another reason to get an echo, though, in someone who has WPW?
Mm,
Are there any congenital lesions that could be associated with WPW that might be challenging to ascertain on physical exam alone?
Um, maybe, if there's a small AST,
No,
would be
AST
hard to
is
tell.
not, to my knowledge, is particularly associated with WPW. But
Um,
there's a big one that starts with an E that's very heavily associated.
Epstein.
Mm-hmm.
Um,
Yeah, of course.
uh,
Epstein's anomaly is something some people estimate that up to 50% of patients with Epstein's have tachycardia, and a large percentage of those have WPW, often with
mm,
multiple pathways. When we know we have an Epstein's ablation, you can guarantee that I will be in a bad mood that
mm,
morning because usually it's going to be a very challenging case. Um, okay. Yeah, so you'd want to rule that out. Certain
mhm,
forms of L transposition can have it, although the morphology and the axis of the non-preexcited beats does not suggest that at all. And then hypertrophic cardiomyopathy can be associated with WPW. And so usually the ECG is a very sensitive tool for something being wrong. In this particular case, I don't think we see any obvious abnormalities. So Okay. Anything else you'd want to look at on the Zeo patch beyond the absence of SVT or the presence of SVT?
um, I guess you can see what his baseline heart rate is too, especially if they consider him starting Ritalin.
Okay. I mean, what is, just for the sake of discussion, if somebody is starting Ritalin, is there any evidence that it really increases the chances for arrhythmias?
No.
No, there really isn't, almost none. There may be some case reports, but generally speaking, there's no large-scale studies that I'm aware of that definitively show
Mhm.
that it's a higher risk for tachycardia. Are there any hemodynamic effects of Ritalin or stimulant medication like those that class that actually is a concern sometimes? Like if someone comes to you, so I personally don't think that people starting Ritalin need to be seen by a cardiologist, but you're going to find in your career that that's going to happen quite frequently. Is there anything though that you would, so write your letter back to the doctor politely saying that, this patient is fine and probably didn't need a consult in the first place. But is there anything that you is there anything that you would advise that the doctor keep an eye on in somebody on Ritalin from the perspective of the heart, the vascular system, et cetera?
Um, I mean, would it be if they're consistently in sinus tachycardia on the Ritalin?
Well, it actually, I do think that in general, I don't know if anyone's ever done this study, but it makes sense that their sinus rate is going to be a little faster than the average because it is a stimulant medication. So that's true, but that doesn't usually worry us. I mean, if you're a little bit faster sinus, you don't usually get a myopathy from that. The thing I'm thinking about is blood pressure. Blood
Mm,
pressure is actually the one thing that has been demonstrated definitively to go up in a large enough percentage of patients on these medications that it needs to be monitored. So it usually is a modest increase, so if you're normotensive, at the 50th percentile, you might be normotensive at the 65th percentile, but it's unusual to get very hypertensive, but if you are already hypertensive or borderline hypertensive, these agents may kick someone into being a full-blown hypertensive. So it is worth, at least if you start a patient on this type of medication, I think it's worth repeating the blood pressure a couple of times after it's been started. And usually I'll recommend doing it once the patient is on what they believe to be the appropriate dose. As you know, there's oftentimes they have to adjust the medication dose, and oftentimes the starting dose is not adequate to treat the problem, et cetera. So, but yeah, blood pressure is the main concern. And the question comes up sometimes with stimulants for long QT syndrome, where most of them are actually potentially dangerous. And in those circumstances, what I normally do is we have a long conversation in which so-called shared decision-making is made, and we decide together how important we think the medication is and how helpful the medication is to an individual patient. As we all know, there are people who have ADHD in whom they are absolutely not functional without their medication, in which the indication for a stimulant is very, very, very strong. And then there are other patients, and again, I'm not a psychiatrist, so I don't want to pretend to be an expert in this, but there are certainly patients I think we've all seen whose parents would like them to do better in school and focus a little bit more, but are doing fine. They just could do better, in which they're functional, but maybe they would be slightly more functional with it, in which case, if there were a contraindication to the medication, we might more seriously take that contraindication. So, all right. So the point I'm trying to make here is that we talked about this a couple of weeks ago. According to the 2012 recommendations, if you have intermittent ventricular preexcitation and you are asymptomatic, according to those recommendations, you don't have to do any further testing on this individual. This patient would be considered to be at very low risk for sudden cardiac arrest, because this tracing shows that at rates above about 80, there's no conduction through the accessory pathway. Now, here's the interesting thing. This same patient had a ZO patch and had 1-to-1 preexcitation up to 187, maximal sinus rate on that 48-hour tracing. And so, it should give some insight into the fact that a lot of this non-invasive stuff is hard to interpret. If we were to follow the 2012 recommendations, this ECG alone would be, in an asymptomatic patient, would be considered adequate rationale to not do any further testing. And yet we have documentation that there's 1-to-1 conduction via the accessory pathway to 187 beats per minute, which would not be predicted, right, on this tracing, where at this slowish rate in the 60s to 70s, we're not pre-excited. So I think it's fair to say there's a lot we don't actually know about WPW and risk prediction. And that's one of the reasons why a lot of electrophysiologists are moving to at least considering formal testing of all WPW patients, and probably even attempting ablation, albeit, with less aggression in a patient who has WPW. Just a couple of weeks ago, I ablated somebody who had a low-risk pathway, but we were already there. We had taken all of the other risks of the procedure, and the pathway was not in a potentially dangerous location for various things like heart block or coronary injury, and so we went ahead and ablated it. But whether that was the right decision, I don't know, but that's what we did. Okay, any questions about this? All righty. This is the last question of the day. What is the mechanism of the tachycardia, and how does the tachycardia terminate? Just to remind you that for some reason there's a couple of RA catheters in this patient, but the coronary sinus, this is the mouth of the coronary sinus or the os of the CS, and this is the distal CS here. And you can see here, these 4 beats are the tachycardia beats, and these are afterwards. So what do you think? Why don't I ask Dr. Kalis, the star of the Mount Sinai Imaging Symposium this weekend?
All right. Good morning, Dr. Path. All right. So it looks like when we have the tachycardia beats, we have the V coming before the A. You can see that in our CS leads. And it looks like it's closest in the distal CS.
Mm-hmm. So does that give you any indication of what the tachycardia mechanism is here? So you're saying that the VA interval is tighter
Mm-hmm.
distal CS than it is in the proximal CS. Okay.
Yeah.
Okay. So
And so if it's like being conducted retrograde, like through an accessory pathway, it makes me think it would be a left-sided pathway.
I agree with that statement. So what's happening here, right, is we're going down the AV node and then up the accessory pathway. Now, the tachycardia terminates here. So does it block in the AV node or does it block in the accessory pathway?
It blocks in the accessory pathway.
Right, because we're going down, we went down the AV node, A to V, but then we don't come back up the A, up the pathway. So this blocked in the pathway. Now, the other hint that this is a left-sided pathway is that in these three sinus beats, we see that the A and the V, right, we see that the AV in the mouth of the coronary sinus is wider. As we get more and more distal, the AV interval becomes tighter, suggesting that there is what we would call eccentric atrioventricular conduction. Normally, the HIS V, corresponding to the QRS, would be the earliest V, and every V in the CS would be later and later and later because we would be depolarizing the left side passively, and it would take longer to get out to the CS. But because we have an accessory pathway, we actually can pre-excite the ventricle on the left-hand side earlier than usual, and so the AV interval is shorter. And so not only do we see that there is an eccentric retrograde pattern in tachycardia, but we see also that antegrade in sinus rhythm we can see as well that the earliest antegrade A is probably either in CS68 or CS8 here. Here's another interesting point. If you look at the surface electrocardiogram, you see that there's not really any evidence for pre-excitation, right? The PR interval looks pretty normal here. And that should give you, and that's interesting. And the reason for that is because the pathway is so left lateral that the AV node is, and the AV node is so much closer to the sinus node that the ventricle is essentially being depolarized normally through the AV node, his Purkinje system, and before it has an opportunity to get all the way out to the left lateral pathway. So the surface electrocardiogram here is a little misleading regarding whether the patient is pre-excited. And this is one of the reasons why I don't necessarily consider intermittent pre-excitation as a proof that somebody is high or low risk, because you can see that in sinus rhythm on the surface tracing, you might not even tell that the patient is conducting through the pathway, but we clearly see that it is conducting through the pathway when we look at these lateral these lateral CS leads. So sometimes people ask me about whether it's high or low risk, and I often say that I don't trust the stress test or this intermittent pre-excitation as much when the pathway is left-sided because of just the normal physiology of AV nodal conduction in healthy young people, which can be so robust that the pathway may appear to not be conducting when it actually could, if asked. Okay, any questions on this one? All right, I think we'll stop at this point. I hope everyone has a great day. See you later. Bye.
Thank you. Bye.